Okie dokie, good morning, everybody. It's just gone 7 o'clock. I'd like to welcome everybody to our first formal Friday Grand Round session of 2026 and wish everyone a happy new year. This morning, we're joined by Dr. Aly Valji. He's one of our R2 residents, and he's going to talk to us this morning about a very important topic, which is peri-operative caffeine. So I can see a few cups of coffee with us here this morning. My understanding is Dr. Valji is going to be talking to us about caffeine in the context of patients rather than of staff. So it's probably already a given that we are all caffeinated. Dr. Valji did his medical school at the University of Calgary, and as I say, he's currently with us on our residency program in his R2 year. At the moment, he's working in pediatrics in PICU before he moves on to the Alex next month for a couple of months. So without further ado, I'll hand over to Dr. Valji. Thank you very much.
Awesome. Thank you, Dr. Brown, for the introduction. So yes, in fact, today we'll be talking about caffeine for patients. So it's quite an interesting topic that I'll get into. Lots of different potential uses for this in the perioperative area. So to start off, just want to thank Dr. Mozeni for her help with my presentation. Some of the objectives I want to get into today, first, to understand the basic pharmacology of caffeine. Next, we'll go through some of the key studies on perioperative use of caffeine. So the areas we'll go into will be perioperative headaches, GI function, postoperative pain, nausea, vomiting, and then anesthetic emergence and some neurocognition stuff at the end. And then at the end, we'll go through some of the future directions this might go for caffeine in the future. So just some background first. As you all know, caffeine is one of the most widely used stimulants in the world, coffee and tea being the main sources. It's quite widely studied within literature in terms of the acute and chronic uses of caffeine. That being said, in terms of perioperative things, it's not as widely studied. Important to note, just to set the stage, that withdrawal symptoms can be observed for caffeine. These can be as little as for 100 milligrams a day, which is just about 1 cup of coffee. And those can be things like headache, nausea, irritability, and fatigue. Currently in Canada, not a whole lot of uses for caffeine medically, the main one being apnea of prematurity. And then, as everyone knows, we can use it for post-oral puncture headaches, can be used for seizure augmentation and ECT, but those are more off-label applications. For reference, as I was saying, 1 cup of coffee is about 100 milligrams of caffeine, 1 cup of tea being about half of that. And then in terms of the pharmaceutical formulations, it comes in two different forms, one being the caffeine citrate and then caffeine sodium benzoate. They're both just half caffeine. So when we talk about it throughout the presentation, 100 milligrams of one of those would just have 50 milligrams of caffeine, for example. In terms of pharmacodynamics, caffeine is part of the drug class methylxanthine. In terms of the mechanism of action, it's an adenosine receptor antagonist, and it affects all 4 types of adenosine receptors, which I'll get into next. It's also a weak phosphodiesterase inhibitor. Dosing-wise, we dose it by total body weight. So just some more background on adenosine receptors. These are located all over the body. Some of the main effects to focus on for this presentation that would be an agonist are things like inhibition of excitatory activity in the brain, negative inotropy, negative chronotropy, negative dromotropy, can cause some bronchoconstriction, decrease gastric acid secretion. And again, those would be by an agonist. So for caffeine, that would be basically the opposite effect. In terms of pharmacokinetics of caffeine, absorption is mainly PO and IV formulations. There's also some rectal ones, but I haven't seen a lot of people using them in literature. The uptake is very rapid, near 100% bioavailability, minimal first pass metabolism. It peaks quite quickly with the IV formulation in 5 to 10 minutes. It distributes very rapidly all over the body. It can pass all biological membranes, the placenta, the blood-brain barrier, everything. Metabolism-wise, it's hepatic, and then excretion is renal. So just to kind of go over some of the physiologic effects of caffeine, essentially all the opposite of everything I showed in that previous table. The main things that I want to highlight here are things that it promotes arousal and wakefulness, as everyone probably knows already. It can have improved cognition. It can increase inotropy, chronotropy, and dromotropy. Can cause some bronchodilation, respiratory stimulation, and then as well in the gut, it can have increased gastric acid secretion and increasing motility. Some of the contraindications to administering pharmaceutical caffeine, obviously allergies, hypersensitivity, but it also decreases the seizure threshold. I wouldn't give this to someone with a PHIO or tachyarrhythmias, of course. Important to be aware of hepatic and renal impairments. And then in terms of pregnancy, the SOGC just recommends to limit to less than 300 milligrams a day for those patients. So keeping all that in mind, it brings a lot of different thoughts into my head about ways this could really be used perioperatively. So if we think that, caffeine causes withdrawal headaches and nausea, if we were to give this to someone when many of our adult patients are chronically caffeinated, could this prevent postoperative headaches? Could it prevent postoperative nausea? If we think about the gut, if it's going to be increasing gastric acid secretion and motility, if we give this to patients, could they get faster return of GI function after surgery? And then the most interesting part I find is if it's promoting arousal, wakefulness, and cognition, could this just wake patients up faster from anesthesia, let them have faster brain recovery, and maybe even decrease postoperative pain? So I wanted to start off by going into perioperative headaches first. So this is a study that I found that came out of Switzerland that was published in CJA. For this study, they did a single center randomized control trial with 40 patients where they essentially documented the amount of caffeine that each of their patients took daily. They divided it in half and gave it to the patients half pre-op and half post-op. As you can see, the inclusion criteria was, of course, quite narrow, limited to healthy patients. And then want to highlight as well that all of these patients were chronically caffeinated with at least 200 milligrams of daily caffeine. Again, that's only about 2 cups of coffee, though. Results-wise, they found that there was a very significant reduction in headache in the caffeine group, but they didn't find any change in their secondary outcomes, which were nausea, fatigue, and unsteadiness. This second study that I've selected for headaches, this one came out of the Mayo Clinic where they tested IV caffeine on patients for ambulatory surgery procedures. So again, this one was a single center RCT where they had about 230 patients. They gave half the patients 200 milligrams of IV caffeine in PACU. They also allowed any patient in either the placebo or caffeine group to request a caffeinated beverage in PACU. So it's a bit confusing, but essentially this made 4 different groups in their study where what first group had just IV caffeine, the second group had IV caffeine as well as a caffeinated beverage, the third group having just placebo, and then the fourth group had placebo plus a caffeinated beverage. Again, they only selected patients, though, that had a daily history of caffeine intake as well. But they did find that there was a statistically significant reduction in headache in those groups that had the IV caffeine and the group that had a caffeinated beverage only. Interestingly, for some reason, they found in the group that had both IV caffeine and a caffeinated beverage that there was no reduction in headaches. They postulated that maybe this was because there was an optimum dose of caffeine and people were quote unquote overdosing on caffeine that was having some adverse effects. But I think these 2 studies were really interesting, albeit with narrow patient populations that were showing that, hey, maybe there's something here. It's difficult to generalize, of course, given that, as we were saying, all the patients in these 2 studies had a history of chronic caffeine. So it's hard to know, were we treating withdrawal or was this intrinsic effects of the drug itself? Next, I wanted to get into some of the GI function studies. So this first study on the top here came out of Germany. This was a multi-center RCT with 80 patients where they took patients that were undergoing open or laparoscopic colectomy for either cancer or benign surgery, and they randomized them to water or coffee 3 times a day post-operatively. They found that there was significantly shorter time to first bowel movement with coffee, but no difference in some of their other outcomes that was like first flatus or time to solid food tolerance. The second one that I've shown here, again, was another study out of Europe, single center RCT with about 100 patients. Again, they picked patients only that were undergoing left-sided colectomy for malignant disease. Here, they randomized patients to caffeinated coffee, decaffeinated coffee, and water. And they actually found that there was a significant difference, but that the decaffeinated coffee group had the fastest time to first solid food and to first bowel movement. This third one that I've got here for GI function, this one was testing green tea. This one came out of China. It was a single center CT with 80 patients where they looked at patients who had robotic or laparoscopic gastrectomy for cancer. They randomized to green tea or water post-operatively, and they found that there was a very significant shorter time to first bowel movement, first phletus, and first solid food with the green tea group. And then this last one I wanted to highlight here, this one came out of Switzerland. It was different than the other ones that I've highlighted because this one they actually used oral caffeine tabs. And so they didn't use coffee, they didn't use tea, it was just pure caffeine. They randomized placebo versus different doses of caffeine, and they found that there was actually no difference between any of the groups. So overall, very mixed results here from the different studies. But I think the last trial really shows here that caffeine actually didn't seem to make any difference in postoperative bowel transit function. But we saw with the other ones that when people got tea and coffee, there was some sort of difference, making it seem like maybe there's something else in the tea and coffee that was causing this and some sort of other compound and not the caffeine itself. Next, I wanted to go into postoperative pain. And so these are two very similar studies, actually. The first one came out of Baltimore, where they took patients who were undergoing oral surgery. They had about 300 patients that they randomized to various different groups, different doses of Advil, as well as combinations of Advil and caffeine. They found that all the active treatments were, of course, superior to placebo. But the interesting part of their findings was that they found the caffeinated combinations with the ibuprofen had much quicker onset and much longer duration of analgesia. This second study, as I was saying, very similar to the first one, came out of Oxford. This one, again, they just tested a very narrow patient population of people undergoing impacted molar surgery under general anesthesia. Again, randomizing to various different groups of ibuprofen or combinations of ibuprofen and varying doses of caffeine. And again, they found that the caffeine combinations with the ibuprofen had much quicker onset times compared to the ibuprofen alone. But it was quite interesting that they found that that was only with the 100 milligram and 200 milligram doses of caffeine, whereas the lower dose, again, here didn't have as much effect, indicating that perhaps there is some sort of optimal dosage of caffeine where we could actually be underdosing as well. This next one here for pain, quite interesting study that came out of a group in Michigan where they wanted to look at effects on opioid consumption if they were giving caffeine and if this could have a synergistic effect here as well. There is some evidence in the literature of caffeine being synergistic with opioids, but it's mostly in chronic pain patients and nothing documented for acute pain. So they did this RCT at their single center with 60 patients, just patients who were doing laparoscopic colorectal or GI surgery. They noted that everyone had very similar anesthetic plans, but they didn't give any exact descriptions of medications provided or how much opioids were given intra-op or anything. They then randomized the patients to IV caffeine versus a placebo, and they found that there was actually no difference in the cumulative opioid consumption until post-op day 3. But what they did find that was significant was they found a large reduction in post-op delirium, which they assessed by CAM up until post-op day 3. Overall, for these pain studies, I think it's pretty interesting to see that there was this synergistic effect with ibuprofen, albeit in very narrow patient populations. Unfortunately, didn't get the same effect here with the caffeine as we were hoping for, but these findings that they had of delirium here sparked some other studies that I'll get into coming up soon. In terms of post-operative nausea, vomiting, again, an area where there's not a lot of studies going on. This is actually the only study I could find on the topic. And so this was a group from Harvard where they took patients who were undergoing ambulatory surgery. They only included patients with APFL scores of at least 2 or greater, and they randomized them to IV caffeine versus saline 15 minutes before emergence. Of note, they also gave all the patients in the study standard antiemetics as well, being 8 milligrams of dexamethasone or 12.5 milligrams of dolasetron. And then patients that had APFL scores of 3 or 4, they actually gave them either Maxaran or a scopolamine patch, the decision of the two at the discretion of the staff anesthesiologist. They found, interestingly, that there was no reduction, there was actually an increase in nausea in PACU in the caffeine group, but no difference in vomiting, no difference in use of rescue agents or in nausea or vomiting over 24 hours. Interesting study because it didn't really have the intended effects that you would think, thinking about it logically, as well as like what the authors hypothesized. They were thinking that, they have a very narrow patient population here where they only took patients with APFEL scores of greater than 2. They also, of course, gave them all the standard antiemetics because it would be hard to design a study where they didn't treat the nausea at all and then tried to see if caffeine helped. But yeah, difficult to see here, like if there was actually effect and what that might be. Going into anesthetic emergence and neuro-cognition. So this is a animal study that I wanted to share. This one came out of Chicago where they tested rats with different drugs on isoflurane anesthetized rats and then measured the recovery time from anesthesia. They found that caffeine accelerated recovery from isoflurane as well as propofol Tiva anesthesia as well. And so this then was able to spark a lot of other studies that have been up and coming that I want to get into next. So this study here, this one was one where they tested IV caffeine for patients with obstructive sleep apnea who underwent uvulo-palatopharyngoplasty. And so they had 60 patients in their study, all ASA 2 or less. They gave them all almost the exact identical anesthetic, which was just propofol, fentanyl, and atracurium, maintained with sevoflurane, and no long-acting narcotics at all were given. They then gave them either caffeine or normal saline placebo at the end of the procedure and only used ketorolac for pain and PACU. They found very interestingly that recovery times, which they measured in various different ways, time to eye opening, time to extubation, as well as duration of stay in PACU, were all significantly shorter in the group that got caffeine. They also measured BIS values after they gave the caffeine and found that these were significantly higher 3 to 11 minutes after they gave the caffeine. And then they found as well that the adverse respiratory events were much lower in the caffeine group, being things like laryngospasm and PACU, reintubation, desaturation and PACU. This next study I wanted to share, this one came out of Chicago, was actually a human volunteer study where they had 8 human volunteers that they anesthetized 2 different times with isoflurane for 1 hour. The only other drug they were given was a propofol bolus to place an LMA in the volunteers. And then during the final 10 minutes, they either randomized to caffeine or placebo. They found, albeit with a very small patient group, that emergence time, which they measured by gag reflex to LMA, was significantly less in the caffeine group, actually being 42% faster wake up. They then wanted to test psychomotor testing to see if this was helping brain recovery as well. Unfortunately, they didn't find any difference, but they had a very small patient group, of course, and actually only one of the subjects in the placebo group was awake enough to complete testing, while 5 out of 8 were. But most importantly, I think they found that there was no adverse events in any of the patients that they had in this study. This next one is actually a retrospective study that came out of a group at the Mayo Clinic where they were looking at patients that came to their PACU who were oversedated, which they defined as Richmond agitation sedation score of less than 0. They actually already have a protocol in place where they do administer caffeine in their PACU to patients who are oversedated. And so they retrospectively went through chart analysis, comparing the patients that got PACU that weren't. And they found that a single dose of caffeine that they gave to patients was associated with much higher Richmond agitation sedation scores at PACU discharge. Lastly, wanted to share this trial, which is actually the same group that did that laparoscopic surgery study where they wanted to look at opioid consumption, the one where they found that delirium was decreased. Because of that, they started this next study where they wanted to look at delirium and caffeine. Unfortunately, it's not quite done yet, but it's still ongoing trial where they have 250 patients. They're randomizing to different doses of caffeine versus placebo, and they're going to be assessing delirium measured by CAM as their primary outcome with some other things as secondary outcomes as well. Overall, I think the area of anesthetic emergence caffeine is probably the most interesting one. There's some good evidence here, I think, albeit in very small RCTs, for caffeine being able to accelerate emergence from volatiles as well as propofol. Evidence for neurocognition recovery so far is not so great, but again, not too many studies have looked at that. And I think that this one on delirium will be a really interesting one to keep an eye out for. That'll be coming out soon, hopefully. I wanted to share some of the current clinical uses of this as well. So that same group that did that study out of the Mayo Clinic, in their PACU, they have a protocol in place where they give 250 milligrams of caffeine, sodium benzoate, which is 125 milligrams of caffeine for oversedated patients. They don't really have any criteria or ways that they get people to administer it, but it's more so just based on discretion of the anesthesiologist, and then they're hoping to analyze it later on. As well, the Michigan Medicine in Ann Arbor, they have a similar thing where they give 250 milligrams of caffeine to patients who have a history of delayed emergence or who are experiencing oversedation in PACU. Again, they don't have like guidelines or anything, but they mostly just do this at the discretion of their staff. So in summary, caffeine is a stimulant which works as an adenosine receptor antagonist as well as a phosphodiesterase inhibitor. It's got a lot of theoretically useful properties that could be used in the perioperative period. To summarize some of those things we talked about in terms of perioperative headache, the studies have showed that there was a statistically significant reduction in headache. It's hard to know, though, if this was related to just treating withdrawal or if this would have as well, intrinsic effects of the drug for patients who weren't chronically caffeinated. In terms of GI function, very mixed results. It seemed that there was a faster return of bowel function, but it might be related to another substance that's in coffee and tea and perhaps not only caffeine. Again, with post-operative pain, we got some mixed results as well. Caffeine did seem to have a synergistic effect with NSAIDs, albeit in a very narrow patient population, but didn't have that same combination effect with opioids when it was tested in laparoscopic surgery. For PONV, contrary to what we would think, that one study didn't show any effect for nausea, vomiting, which was really interesting. Although, like I said, I think that was a really hard area to test it in. And then lastly, for anesthetic emergence, neurocognition, there's some good evidence in the animal study as well as the human study that show that there could be accelerated emergence from volatile anesthesia, albeit again with small sample size. Some evidence so far that this could have an effect on postoperative delirium in PACU. And then there's that dedicated trial that's ongoing that'll be coming up in the future. I think important to note as well, most of these studies that I presented today, they're all with basically ASA 1 to 2 patients, quite exclusive criteria that they use to include in their study. That being said, almost none of them had any adverse effects that happened to any of their patients. So in terms of going forward, I think it's a really interesting area, but there's some things that need to be done. I think we need some larger studies. One, to be able to provide guidance on dosage if this was to be used, given there's extremely wide range of things people are doing in literature. Two, to be able to help with identifying any adverse effects and their incidence, because we didn't get much of that in any of these studies, like I said. And of course, not going to try and give this to someone who has coronary artery disease and AFib and many other things going on without having some further studies on that first. And then we need some larger studies as well to clarify the effects on anesthetic emergence. I think important as well to be able to delineate whether this is effects from caffeine itself, or are we just treating withdrawal of caffeine in an adult population that's chronically caffeinated. That this will help us generalize it as well to a greater population. And then also in terms of GI function, whether it was caffeine itself or whether it's other substances in coffee and tea that are having that effect on postoperative ileus. So thanks everyone for listening. Would love to welcome any questions. Hi.
Is this something we should ask patients about, about their caffeine use? Is it something that we should worry about patients going into withdrawal, or conversely, should we worry if your ASA3 patient with their coronary artery disease and their phagocytomas are at home drinking 4 coffees a day? Is that something we should worry about? Or
Yeah. So for Zoom, the question was, should we be asking patients about their caffeine intake pre-op, and is that something that we should consider? I think so. I think that is something important. Of course, a lot of patients are chronically caffeinated. And these studies have shown also that patients who are chronically caffeinated are at risk for things like those withdrawal headaches, greater nausea, vomiting after surgery. Although like it's unclear if giving caffeine could treat things like postoperative nausea, vomiting, like we went through here. I think it's important to know because it could make us just aware of things that they could experience after surgery, and we can have a greater increased awareness of being able to try and treat some of those things prophylactically. And that might, and probably right now it's with other medications, but in the future, this might be something that on our pre-screening, if we ask people how much caffeine they take, or we have a chart, or we can pick, oh, they should get this dose of caffeine perioperatively before surgery, something like that, maybe. Hi.
I just looked it up, and Tylenol 3 has caffeine. Right?
Yes. Yeah.
It's only 15 milligrams.
Yeah.
According to all this, would seem like a very low dose.
For sure. Yeah.
If we're giving T3, should we maybe be supplementing additional caffeine for actual benefit?
Yeah. So the question for Zoom was that Tylenol 3s have caffeine, but it's a very small amount. It's about 15 milligrams. And if we're giving T3, should we be supplementing caffeine then? I think it's interesting thought. There's a lot of studies that have shown that for like they're non-perioperative studies that of course have shown that caffeine has synergistic effect as well with Tylenol. So I think generalizing those probably the perioperative period, it would be effective to supplement that. But of course, there wasn't any studies that really compared Tylenol synergistic effects perioperatively, but most likely I think it would be. And it's, I think, intervention that in a healthier patient is quite harmless with little side effects, but could have big upside. Yeah, yeah. Um, is there any things in the Zoom chat, Dr. Brown, at all? Or I can't really pull it up. Okay. Yeah, so diuretic effect is real, of course, as we all know. They did find in some studies that it has a very variable effect on renal blood flow, and it kind of depends on genetics and a bunch of other things as well. So they weren't able to find anything like if it would increase how it would affect creatinine and perioperative renal function. So it's hard to say whether that would be something that we'd have to consider giving to patients. And I think that once we get bigger studies, if we're checking for adverse events, that would be one of them, I think for sure. Like we're not going to if we want to give this to someone who has renal dysfunction and things like that. But so far, nothing really has come out of that.
I did a study with it getting caffeine was orally and IV.
That one was orally. Yes, yeah, yeah, yeah. Okay.
I used to work in a hospital where their enhanced recovery pathway for hip and knee replacements was, well, it was OxyContin first of all. But part of their enhanced recovery was a cup of tea or coffee out in recovery. I always thought that was just it's a nice thing, they wake up from their sedation and they get a cup of tea or coffee, but maybe there was something more to it than that. If there's no other questions in the room, and it looks like there's no other questions on the chat, then I'll just leave it to say thank you very much to Dr. Valji and good day, everyone. Thank you.
Thanks.